can ask questions of any of our panel speakers here or myself. So who would like to begin? Question? Yes.
Yes. For TMS alone?
We'll need to repeat all the questions so that the viewers at home can have the benefit.
Should I repeat the question?
Grace is going to, but... Okay, so the question was, what's the success rate? How many people walk away from your course of treatment in remission or significant reduction of pain?
Well, let me start with the caveat that it's not a treatment for all people or all illnesses. But for the people who it's an appropriate choice, over 90% have gotten very satisfying relief. There are no cures, not for the depressive illnesses or depression comorbid with pain or so-called simple central pain. But people are able to go back to work and life and school and be able to participate in an ordinary way. They might be on medicine, but at non-destructive doses. That means finishing the course of treatment. So people with highly comorbid pain and mood disorders might need 30 to 50 treatments spread over 3 to 4 months. It's a real task. There's nothing simple or pleasant about it.
That's her.
One of you guys have a cell phone or something?
Okay, just like school, should be your cell phones
Or on the front row, there's a cell phone.
You should turn his mic off when his mic's being utilized.
No, it's not the microphone. That's the cell phone interference.
You guys are bad. Please give me your phone. There will be no texting in class.
I didn't listen to my provider.
99% of the time, that's what.
Okay, is that better? Kids these days.
They don't like cell phones on airplanes, and that's it.
Okay, next question? Yes, ma'am. Okay. Okay, the question is, why is it so difficult to find a provider that does inpatient ketamine in Illinois? Inpatient ketamine infusions in Illinois.
Well, I'll try to field that, but I want to remind everyone I don't do hospital-based work. I think the primary reasons are twofold. One, it's really expensive, and just as importantly, there's really no good evidence that it's effective. Putting people in a ketamine coma, so to speak, when they're in acute pain, say after a profound burn injury, is life-saving. But for a chronic pain syndrome, like CRPS, it doesn't help. The few people it helps are having an overlay of acute pain. The only other way that it's been shown to be effective is it can reduce the use of opioids, which can make it easier to treat the chronic pain syndrome long-term, not acutely.
Okay. Yes? Okay, the question was, on that same point, are you saying that ketamine alone does not help, or just the inpatient ketamine infusion does not help? Ketamine coma?
Yeah,
does not
I was
have.
referring to these long-term infusions, 3 and 5 and 7 day long, to nearly anesthetic stage of obtundation or relative unconsciousness. Ketamine is effective in around 2/3 of the patients for whom it's appropriately chosen. It still needs to be utilized properly, meaning it isn't effective in 1 or 2 or 3 infusions. It takes quite a lot of work to get rid of a horrible illness.
I just wanted to add that it depends on where you go and what protocol they use, what their success rate is. So wherever you go, I don't think it's available in Illinois for inpatient. It's legal, but it's not eligible, like it's not provided right now here in Illinois. But there is places around the country that you can get it inpatient. There's only a few places left right now. And a lot of it has to do with hospital policy. The hospitals just don't want to invest that much money into a patient that's laying in a bed in ICU for 7 days or 5 or whatever their protocol is. But the protocol matters, but they also have found that the booster therapy is a must afterwards. So even myself, you have to go through boosters. Even like Dr. Bess is saying, it's not like you go and you get your 7 days and then you're gone, you're done. I've ended up back in my wheelchair because I've had major injuries, like I burned my hand or I stepped on something that impaled my foot, and I had to go back and get ketamine again. You have to continue to get boosters. So even if you do the 7-day inpatient, it doesn't mean you're done. You're still going to have boosters if you continue with that course of treatment for the rest of your life.
Okay, that leads me into actually 2 questions from viewers at home that were directed towards the same thing. One was for Dr. Best. Do you do ketamine infusions alone, or do you only do the TMS ketamine combination therapy, and why?
We have done ketamine infusions alone, and we've also had people come to us that had already begun on ketamine infusions alone at other facilities. I will do them if someone asks, but I don't think they're as effective. I don't think they're as useful. And our comparisons, both for patients that started with us or had ketamine infusions at other facilities and then trying the different technique that we're using, is that it's apples and oranges. It feels different and it gives different outcomes.
Okay. And then pertaining to what Barbie just said, another question is, would your TMS ketamine treatment be a lifelong treatment like other medications or treatment modalities in order to maintain the pain reduction?
When patients get better, they might need occasional tune-ups. Sometimes it's out of the blue, just like CRPS typically occurs out of the blue. And other times it's predictable. There's been a fall or a burn or whatever kind of insult to the nervous system might create a situation where a person needed retreatment. Obvious ones are things like when there's a dental infection and somebody might need 1 or 2 treatments in order to just overcome it.
Okay. I had another one from home. I apologize. Again, it's for Dr. Best. Actually, this was actually for Dr. Best or Dr. Ingatowski. Okay. This actually was for Dr. Best or Dr. Ingatowski. It said, can taking ketamine orally be as effective as infused ketamine? And it said Dr. Best or Dr. Ingatowski.
No, since we only give it through injection, I can't really comment. We haven't given it orally to the animals at this point.
Okay, thank you.
Availability of the chemicals around 20% when taken orally. So you, just with those rough numbers, you need 5 times the dose.
20% when taken orally.
Right. Now, the other half of that is that you can no longer control the treatment itself. When we're using an IV pump and we're giving somebody an infusion over 30 or 40 minutes, if the anesthesia provider becomes uncomfortable with anything that's going on, or if the patient does, or if the patient's loved one does. For instance, some people can have upsetting experiences while receiving the medication, you can't stop that once it's already in the gullet. There's no way to remove it from the stomach. You can't suck it back out, but you can stop the pump. Ketamine is a very short-lived chemical in the body. The second the pump is shut off, within a few moments, the blood levels have dropped appreciably. So it's safer. I don't mean that it's wrong to give people oral or nasal ketamine, but it's nothing to do when somebody is initiating treatment. It would be something that somebody would try once they already know how ketamine affects them.
Okay. Any questions? Yes, ma'am. That's a great question. So what is the incidence of an adverse reaction to the combination therapy? Infusion therapy. And what can you do to mediate that?
The majority of people have psychedelic-like experiences at lower doses when beginning. So an average-sized person might receive 50 or 70 milligrams with the first treatment, and they'll describe odd psychedelic experiences like seeing shapes, rectangles and squares and that kind of thing. As the doses increase, some people, especially people who've been traumatized, might recall some aspects of their traumatization. There are ways to suppress that, meaning giving somebody an additional medication like Valium. And that doesn't really seem to interfere with the efficacy. Nevertheless, it's another drug, and it means that a person has yet more floating around. These are all things that need to be considered. The most important aspects of mitigating adverse outcomes are to have an attentive and understanding treatment provider. So while any licensed physician can obtain ketamine and administer it, if doing so in an ethical fashion, you still want someone who knows about that chemical and how to use it and how to deal with the discomforts that it might evoke.
Barbie?
From the patient perspective, I would say and I've done inpatient and outpatient ketamine since 2009, I would never get ketamine without the other medications that they give me. I get clonidine, Ativan, Versed, Zofran, and that was 4. Then what? And Versed. Did I say Versed? Clonidine, Ativan, Versed, and Zofran. So that I don't have the hallucinations. If I do, like one time I petted a horse and Ken ran it over. And he said sorry, and I was like, it's okay. It was that fast. But I don't remember it. I don't remember any of that. And if I was to get ketamine, I would not want it without those blockers for me personally.
So another patient experience, I've done it both ways too, and I think a lot of people can do it without being sedated. Different types of personalities are able to find a way to relax themselves through that. I wasn't one of those personalities. I did it 4 times, and I just couldn't handle not feeling like I was in control and responsible for myself. It was very hard for me, and I cried, and I'm proud, and I don't like to cry. So I also chose to be sedated. It's not a pleasant experience, but it's worth it because it worked very, very well for me. Yes?
Do you find it necessary to have or not have opiates while using medication for
Do you find it necessary to have opiates or not during a ketamine infusion therapy?
I think what people are asking is if there are absolutes, whether everyone needs to stay on their medicine or whether some people should stop. Is that? Yeah. We're able to rapidly reduce the amount of opioid to something that's non-obnoxious, but the goal is not to get people off of opioids, it's to have them on a medication regimen that is helpful and non-destructive. Some people are able to stop their medicines. That's unusual. It's still a goal. We all wish for it, but I don't see it very often.
So a lot of people ask about the combination therapy. Do you have to wean yourself off your meds to come to the neuroscience center? And that might have been the goal of the question.
Don't have to.
You do not have to, was that answer.
Some locations do make you.
Some make you. So that's a very common question. Do you have to wean off your meds in order to come to the neuroscience center?
Can I say one more thing? If you look up studies by Dr. Linda Watkins from University of Colorado, you can see that there's studies that are done that show that there's glial activation with opiates, and when they put the ketamine in, the ketamine works on those same receptors, and so the ketamine doesn't work as well when you do have opiates in your system, but I encourage you to look up Dr. Linda Watkins' study on that.
This is a great thing to discuss at a scientific level because this is the basis of why we needed the scientists to come talk to us today. There are theoretical interactions between all these chemicals. We should remember them. It took hundreds of years and trillions of dollars to get all that data. Nevertheless, that doesn't mean it was accurate data or that it's helpful. Discovery that these pro-inflammatory cytokines are closely associated with causing and also treating the ailments should make it clear that we're not simply affecting an NMDA receptor or a diversity of monoaminergic receptors, or that we're simply altering cerebral perfusion. There's a complexity to this, and we're trying to sift through it.
Yeah, I fully agree with what you're saying. A lot of what they're talking about here, I truly believe is side effects. I've watched specific, what our goal is as scientists is we're trying to define something more specific with less side effects. At the end of my talk, I didn't realize I was going that far over. We have been getting involved with this new perispinal administration of etanercept, a specific TNF blocker. And it's delivered immediately to the brain, very rapidly, within a minute, by using Trendelenburg positioning. And what we like about it is it affects these systems, but it doesn't have these side effects. It's specifically attacking TNF. And I was just saying to someone before I came up here, every time I read new literature of a new breakthrough on especially depression or pain, if I do a Google on that, TNF is always involved. 100% of the time. And I'll always get a hold of Dr. Ignatowski and I'll say, yeah, once again, we believe in that. We believe that strong in it. That is where the future is going, is blocking TNF. We saw it years ago in animal models, Dr. Ignatowski and I, and we couldn't believe it. Not only did we see a loss in the chronic pain development in these animals, but these animals actually became hyposensitive. And I'll be honest with you, I had somebody once, a couple people once said, wow, for the Army, that would be great for soldiers as they go into battle. I didn't like that, but I understand it. I understand it, It's that powerful. And yes, I believe that all these treatments are going after TNF.
I want to add something. I think Dr. Qua was a little bit on the excessively humble side. Hyperbaric oxygen has a number of effects. It not only alters distribution and concentration of gases that are submerged into the body, it affects stem cell activity, and it's a TNF blocker. I think it's important that we remind people that there's some kind of theme here, that inflammation is associated with chronic suffering.
One thing to add from the patient perspective is that I got HBOT covered by having the doctors cite the vascular constriction that I have, and my insurance covers vascular constriction, and you should try the same thing if you want to try that therapy. You're not going to cover it if you put down RSD or CRPS, but they will cover it for vascular constriction, which is a symptom that we deal with, just to help you get that paid for.
Code 443.9.
Thank you.
Okay, we had a question over here.
I've talked doctors into giving me,
Hold up.
Sorry.
So, A, is ketamine considered experimental, or should it be considered experimental? And B, if the doctor thinks it's experimental, do you want that doctor touching you? Right?
All right. Experimental has a bunch of terms, some of which are law, some of which are based in science or the practice of medicine. There's a common misunderstanding about this word. The FDA does not regulate the practice of medicine. They're interested in safety and ethics. That's what it comes down to. Doctors who are doing reasonable things, for instance, edgy stuff that they nevertheless ran past some basic scientist or the pharmacy or the pharmacologist who's involved, that's not thought of as running an experiment per se. It is an unusual application of an already well-accepted chemical. The most that it might be thought of is as an off-label use. For this and anything else that's off-label, some doctors feel compelled to obtain formal informed consent, not simply a brief chat, but getting a signature on a piece of paper with some witnesses. The bigger issue is whether you should be going to someone who's already scared of the treatment.
Exactly.
And I don't think you should.
Yeah.
Somebody needs to be calm in the room. If the doctor, the nurse, and the patient are all feeling uneasy, that's not going to be a good example for ketamine because people's senses are heightened in unusual ways while receiving ketamine.
Barbie?
Well, I talked my doctor in Arizona into doing it so I didn't have to fly back and forth to Pennsylvania. He had never heard of it. We showed him the pictures of the suite in Pennsylvania at Drexel and said, this is what it is. It's this easy. You can call Drexel and get trained. You can call another provider and find out how to do it. Once he was comfortable with it, I was comfortable with it because I knew, and I had my husband there to say, yes, this is how it's supposed to be. So if they did something different, we knew to stop them. So if you're comfortable, then okay. My doctor ended up opening a 12-patient hospital that all they do is ketamine. So it really depends on your trust in the doctor's trust in you, and you have to be totally comfortable. Do not do any form of treatment if you're not comfortable.
You only get one body, and it's your body, and it's your choice. So you need to do your research, and you need to become your own best advocate. So get in the groups, get with an advocate, get the proper information in front of you. You only get one body.
And I would just add, if you give your address to Ken before this is over, I'll send you a book called Remission Possible that I wrote, and it talks about everything you just asked, so we can get you the information.
Was there a question right over here? Yes. Okay.
The question,
Go ahead.
The question is, with the TNF research of Dr. Ignatowski and I were talking about, the question is it actually being performed successfully in the clinic? That was what I was getting to at the end of my talk, where there's that one picture of Dr. Bess sitting next to a patient in a Trendelenburg positioning. Yes, it is being done. Just in the past year, Dr. Ignatowski and I are getting involved in the treatment center in Florida doing it, who Dr. Bess is also involved with. The drug is called etanercept, Enbrel. You might have heard it on TV. It's right now. It just started this week in Australia going through clinical trials. So it won't be off-label eventually. It's actually in clinical trials to be delivered posterior venous plexus. So outside the spinal cord, they tip the patient into the Trendelenburg positioning. That's what I was starting to say up there. And I said, when you're a kid, remember standing on your head and feeling that pressure? What it does is it forces whatever we inject, or the Dr. Tobinick or Dr. Best injects into the patient, it forces it right to the brain, through the choroid plexus, and into the ventricle within a minute. Completely blocks TNF in the ventricles, and it has profound effects within minutes. We're excited about it. And so it is in practice right now, and we've watched patients in chronic pain. Now, I don't know how Dr. Best works with it, but Dr. Tobinick has to screen you first. He told me a 90% success rate with post-stroke pain so far. And I don't know how many treatments, but I think 1 or 2 treatments. We watched one with 1 treatment, a patient who couldn't even talk. She came in and she was asked to count to 10. She had a traumatic brain injury. And for her to count to 10, she sat there shaking, all nervous, looking up at the sky, and she couldn't get 1 out. She finally got 1 out, the word 1 out, but it was a grunt. And she was gonna work on 2 and gave up. Within minutes after the treatment, she sat there and she looked at the sky and looked at Dr. Gutowski and I, and she said, wow, everything is clear. She spoke perfectly. I mean, I'm amazed. You can go online and look, he's been putting the videos on, and the reason I'm backing him right now is we got nothing in it. It's no interest for us. It's seeing our work coming to fruition, because it's all based on our research. And Dr. Best is doing it. That's that one picture I was showing at the end of my talk. So yes, I truly believe TNF. I believe in it. And this is one compound. We're doing in the lab right now, Dr. Ignatowski and I, she showed where we're knocking down gene expression using nanotechnology. That's not in practice yet. And it's profound what that can do. So it's the same theory, but we're stopping gene expression by using small inhibitory RNA against TNF. And we've actually isolated it to the CA1 region of the hippocampus, that precise. And if we put TNF in, the animal develops pain. If we take TNF out, the animal comes right out of pain very rapidly. I'm excited about it. As I started saying in the beginning of my talk, very few academic scientists really get to see their 30 years of science come to fruition. It's happening, and I truly believe these other techniques are tapping into that, and we're going to learn in the future, I truly believe, in a clinical setting, when we have to use each one of these. But etanercept, Enbrel. It just started last week. Dr. Tobinick has gone through many years. Dr. Best could talk about it. Dr. Best and I, and Dr. Ignatowski has been fighting for him on his behalf, because major drug companies are trying to stop him. I mean, it's pretty crazy, because it is working, and it's that powerful. And right last week, Australia is doing the clinical study. I think one of the things that got them to wake up was one of their big football players. What's football called in Australia? Rugby, yeah. Their big rugby player had a stroke quite a few years ago and has been having all forms of neurological problems for many years. He was treated like that. That's how excited they were. So yeah, I've watched it work for aphasia, chronic pain, gait problems, walking problems, but the one that we're interested in, Dr. Tobinick will call me up a couple times a week and said it happened again today. He treated a patient for chronic pain who's been in pain for years, and it was cured immediately. So what I'm trying to say up there is these other techniques are being honed, and they are. This is a great time, guys. Really, I had a mother who suffered, or a father really, who suffered for years with chronic pain and illnesses years ago. Boy, I wish they were around right now. I really do. You guys are lucky to be in this time, and yeah, you'd be luckier to be 20 years from now, maybe, but I think it's coming on that fast. I've seen the patient we watched, a year later, she was still perfect. But what happened, she had another injury. She had epilepsy on the side, nothing to do with this, slammed her head on the ground again, had some more, he cured her again immediately. One throws, and I mean, I'm not a clinical, so I'm depending on what I've seen him do. and he's cured them in one treatment. But he's also had them where they've come back. He got in trouble a little bit in the beginning because he was treating Alzheimer's, and it wasn't as powerful. We have a theory on that. I truly believe you can treat Alzheimer's with blocking TNF, but a different way. We're working. We have a patent on that through our company, but it's a different way of treating Alzheimer's other than etanercept. Etanercept, remember, is FDA approved for peripheral administration for arthritis and Crohn's disease. So it's different. But yes, I believe this is a new frontier. This stuff does work, and what they're doing. Yes?
Okay.
Oh.
I'm sorry, Pam, go ahead. And then I have another question here, and we need to move on to our questions from the online readers, or viewers. So go ahead, Pam.
I don't know enough about that area. I mean, the neuropathic pain, we're studying diabetic neuropathy right now. It works. I mean, it's beautiful. The results Dr. Idatalski is getting in animal models is profound by blocking TNF in the brain. Remember, this is in the early stages. We don't have all the answers yet. We're excited about what it is working on, but yeah, in the future, we're hoping we get funded pretty soon by National Institute of Health. They're very intrigued with it now. A lot of eyes are opening up. We just got a $2 million grant close to being funded, and I think it's going to be funded. I probably shouldn't be talking about this, but I'm excited.
We
I'm
hope
excited.
it's going to be funded too.
I'm excited about where the research is going.
Brooke? Okay, so the question is, CRPS in the hyperbaric oxygen therapy chamber. The slide talked about the depth of 2.4 ATA for 45 days, and she's wondering if that's 40 dives, I'm sorry, a duration of 40 dives, 45 days. She's wondering if you complete that and then need to come back for more, correct? Can you extend for longer than the 45 dives and then need to get boosters? Can you go longer, or is that it?
Okay, I can only report what was published in the paper. And Dr. Krop and his colleagues did 15 dives over 3 weeks. And then after the last dive, they waited 45 days and tested again, and still had positive results on the range of movement of the wrists and also the self-assessment of pain. They did not report anything going beyond 45 days or whether it took a smaller number of sessions afterwards to continue the therapeutic effect. And frankly, they have not followed up on their study. In our animals, we are currently trying to see what's going to happen. With our current pain model, we do find that we can induce a hypersensitivity to touch that lasts 45 days. And we've also found that if we administer hyperbaric oxygen, that the pain relief, the reversal of the hypersensitivity to touch, also lasts 45 days. Frankly, we've not gone out far enough to see, okay, if we went 60 days or 100 days, you know, is the effect of the hyperbaric oxygen going to wear off? And at what point can we re-administer the hyperbaric oxygen to continue the therapeutic effect? Those are all experiments that we have planned. We're waiting to get funded by NIH on it.
The question was, is it more than just the oxygen, or is it also the pressure that's beneficial?
Okay. We did a study that we published about 2 years ago where we had animals that were subjected to pressure alone, or 100% oxygen alone, or a combination of 100% oxygen and the high pressure. With high pressure alone, there was no pain relief. With 100% oxygen alone, there was also no pain relief. It was only with the combination of high pressure and oxygen did we see pain relief. And we had another group of animals, or a series of experiments where we administered 100% oxygen at increasing pressures. 100% oxygen at 1 atmosphere, like I said, does not produce pain relief. But as we increase the pressure from 1 to 1.5 to 2 to 2.5 to 3, we got a dose-related or pressure-related increase in the degree of pain relief that we observed in our animals.
Okay, thank you. Some more questions from our viewers?
On the subject of insurance cover any cost and the adverse outcomes, how can a patient get an assessment case from the knowledge?
Okay, so does insurance cover HBOT? Are there any adverse outcomes to HBOT? And how can a patient get an assessment to see if they qualify for HBOT?
Okay. I did mention that there were 14 clinical indications for HBOT that were approved by the FDA. Those are generally covered by health insurance. Anything that is off-label, you have to pay for yourself because they're not covered. Let's see, the second part of that question was adverse outcomes. It's 100% oxygen. In our experiments, what we have seen, if the pressure increase is excessive, or if the decompression occurs at too fast a rate, you might induce convulsive seizures. But that's the only thing that we've seen. We can control that by taking 5 minutes to get from 1 to 3 atmospheres. Okay? In terms of qualification for HBOT, I think I'll let Dr. Bess answer that.
So you're wondering what the uses would be or the applications?
No.
How can a patient get an assessment to make sure they know if it's good for them?
Well, I think that the smartest thing to do is for them to do a little bit of research and then find a physician who's accustomed to utilizing HBOT. There are many doctors who know plenty about HBOT. Not all of them have a hyperbaric chamber or center, but they can still prescribe. In our case, we utilize a consultant who is able to talk with the patients and individualize each treatment plan. That's not necessary. Somebody who's already a practitioner who's already adept with hyperbaric might feel comfortable dosing all on their own. But there's still a finesse to this, just like any other drug. Oxygen is a drug. It can only be dispensed with the written prescription of a physician. And there's a reason for that.
Okay, thank you. Any more questions?
For Dr. Spengler. You scan the brain to see what's wrong.
I'm not sure that's what Dr. Spengler does, but Dr. Spengler?
That's it? Can you scan the brain to see what's wrong? That's an open question. Dr. Bess, help me with that.
Can I say my experience?
Yes.
Okay, so I've done 2 fMRIs, one at the University of New Mexico and one at UCLA. And they did actually find that my hippocampus is misshapen and smaller than my thing on the other side.
the thing on
But
the other side.
they actually said that they're finding that in a lot of pain patients. So it is something that they know to look for and they can look for.
You have 2 hippocampi in your brain, one on each side. I know. And what Dr. Gutowski pointed out in her talk is when we harm one side of the rat, it's the hippocampus on the other side that gets affected. And one of the effects is atrophy, which is what you're saying, it shrinks. But I know Dr. Best might have more on this about brain scans that are being used.
Well, the second question that leads into, and probably what would the doc suggest for patients feeling pain or pressure in the brain?
Okay, so what would the doctor suggest? So the first question was about brain scans. The second is what would you suggest for pain or pressure in the brain? So, Dr. Best.
There are a lot of brain scans, and
Yes.
sometimes they're needed, sometimes they're not. There's everything from measurement of electrical to electromagnetic to perfusion parameters. There's specialized brain scans that are typically done in academic centers that can even label different chemicals. Sometimes those are helpful. They're not always necessary. Sometimes they're useless. But when going back to the clinic and somebody who's having pressure or something in their head, they need a physician who's willing to figure out what the problem is. This isn't about machinery. This is about a doctor actually finding a way to answer a question. And it might be through the utilization of machinery, but not simply through a black box like a machine.
Okay.
Still on the subject, she's been experiencing burning. It feels like it's coming from deep inside her brain. It feels like 1,000 beats in this patient. Just kind of follow up with the rest of it. It's not really a question, but she says she's experiencing burning like these things in the brain.
Well, it's probably important to note that the brain itself doesn't have the ability to feel pain within its own tissue. Surgery can be done on the brain without any need for pain kill.
Wow.
Nevertheless, if the person's having that sensation, it's simply another description or example of what we're talking about, which is, so to speak, an hallucinated kind of pain. In my case, I have pain in my leg, even though my leg's missing. That's called phantom pain. It doesn't mean I'm insane. It means that my brain has a major glitch in the way it processes data. It sounds like this patient, or the spouse of the patient, is describing a similar situation. Once again, that's a nice example of why neuropsychiatry can be helpful in assessing these conditions. We're talking about experience, and then we need to extrapolate from the experience to a scientific understanding of the ailment.
Okay, thank you. Any more? Yes? Sure. 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 That's a great question. That list is about this long.
But I got one big one.
You asked Barbie. So Barbie,
Do you wanna repeat it?
please tell us what methods, modalities, helpful tips, tricks, hints you personally use that are not from the medical field.
The two biggest ones that I use music therapy and aromatherapy, but and mindfulness. But the two biggest modalities that I use, one is a product called AlignMed Spinal Q that helps with posture, and it's a vest that you put on and you cinch it to your body where you need the support in your spine to help you with that. Thank you. And the second is called an oral orthotic. If you go to tmjconnection.com, you can find out about it. I have it in my mouth. It holds my jaw down and forward, which takes the pressure off of my TMJ joint. I'm giving you the short version, but it basically, through my fMRI studies of my brain, they showed that it lowers my my spine and brain neuroinflammation by up to 70% with it in. If I take it out, I lose balance, coordination, my arm curls up, my foot curls up, and I beg for ketamine. So I don't really take it out except for to brush my teeth and floss, and that's about it. I had to make one with teeth on it so that I can even wear it to eat.
So could I answer too? Okay, so the everyday tips and tricks that people that do, how many people in here are not chronic pain patients? So we have quite a few caretakers, providers, whatnot. So the things that people like that don't necessarily notice that chronic pain patients are doing, we watch what we wear. We're not wearing abrasive clothing on our affected limbs. We watch the temperature. We need to watch for flashing lights. Barbie talked about the pattern on this carpet. That's not affecting her right now, but that might affect someone else. We watch for loud noises, right? I mean, how many people in here have sirens or loud kids? Or for me, it's a movie theater. My husband likes to go to those adventure movies. Those drive me insane. I can't stand the loud booming noises in the movie theaters. Those kinds of things. We need to avoid that stuff. For some people, it's spicy foods will flare their bodies up. For me, it's cleaning products. I can't use most of the cleaning products that are in Walmart or the dollar store. I have to buy cleaning products that have all natural, ingredients in them. Make Brian clean. That's it. My husband's cleaning from now on. There's the solution.
Mine does.
So the everyday things, soaking in warm water and Epsom salt. That's one of the best things you can do for yourself. Taking vitamins and minerals. Eating healthy food. Knock out the fast food and the crap from your diet. Eat healthy food. Eat like the cavemen. Eat fruits and vegetables and lean meats. There's all these little things that you can do for yourself that don't include the fancy doctors and the fancy treatments, things you don't have to submit to your insurance. There's a lot of little things that you can do for yourself. Watch your temperature. Dress for the weather. You don't even need to dress for the weather. You need to dress for where you're going and what you're doing. You need to rest a couple of days before any event, and you need to allow yourself the time to rest afterwards. Allow yourself that. If you're going to an event, scan that building. Know where the quiet place is. Watch for the bathroom. Even if the bathroom is the place where you have to hide, allow yourself the breaks. And learn how to say no. Learn how to say no. Tell people no. You don't have that ask me to volunteer sign on your forehead anymore. You're sick these days. Learn how to say no. So there's all kinds of things you can do. Lavender. Lavender's wonderful.
I actually had, in my normal presentation, I actually have how to save your energy pennies, and I have about 40 different ideas. For the online version, I will go and add that slide back in, and so Monday, if you go check out the website, it will be back in my presentation.
Perfect. There's a lot of things you can do for yourself that don't include medical treatments. In addition, I'm not saying you don't need those. Trust me, I'm walking, talking proof that they're wonderful. But there's a lot of things you can do for yourself that don't need to be submitted to insurance. Yes, ma'am. Let's get you a mic. Thank you.
Thank you.
And thank you for coming.
Oh, yes, thank you. My name is Dr. Melissa Garrity, and I'm a pain patient and a pain therapist. And something that's so important is having a therapist that's probably trained in chronic pain to be a part of your team. Usually that typically can be a pain psychologist, a health psychologist, or a rehabilitation psychologist. Typically, we're hard to find people who actually know what they're doing. A lot of therapists will say they work with pain patients and they really don't have the experience. But typically we can be found either in private practice or within pain management settings. And that is the most, personally and clinically, the best tool that I found my patients can have is actually being able to have someone who can customize these daily tools for them.
And hopefully your insurance will pay for them.
Yes.
And if not, grab yourself a support group because we're free. Thank you. Thank you for your contributions and thank you for coming. We appreciate that. We love your orange. Yes, Nikki. You want to repeat that question?
Okay, so the question is, what other types of people besides a physician can you bring into an appeal process? I have actually gone with patients to provider appointments as well as appeal appointments, and spoken as an advocate and as the president of the Power Pain Foundation. But there's other advocates that we have, including Gracie, that can go out in this area for the people who live here. But we have people all over the country that can go in with you and that are educated and know what they're talking about. So when the person across the table who knows nothing about chronic pain or the treatment that you need or want, you can say, well, here's an objective opinion, here's the person's credentials, here's what's going on. But it's always best to have your provider there, the one that wants to do the treatment or is doing the treatment for you.
Yeah, and we're networked all across the country and the world these days, actually, and we can make arrangements to have advocates show up at hospitals and doctor's appointments all across the world. We all connect to each other. Yes, sir.
The world, what is the drug they were working with already in Australia?
Can you spell it?
The drug that's being used in Australia for the clinical study is called etanercept. E-T-A-N-E-R-C-E-P-T. Its other name is Embrel. Do you know how to spell it? E-M-B-R-E-L. I didn't want to spell it wrong. It's the same compound. It's a fusion protein receptor against TNF. And it immediately deactivates TNF.
I had never heard of etanercept before I met Dr. Best, but I sure hear Enbrel on TV a lot.
Yeah, you hear about Enbrel.
Yeah.
The drug company that makes it, we're using it off-label. The drug company that makes it is really pushing it a lot for arthritis
I didn't
and
realize
for
they were
Crohn's
one and the
syndrome.
same.
Yeah, it's the same compound. And Dr. Best and Dr. Tobenek are using it off-label right now, but I am really excited that it's in a clinical trial in Australia.
Okay, are there any more questions? Do we have any? Oh, you do. Okay, so the question is it common for people with CRPS to have their tastes and smells and whatnot change? And I'm going to answer that from a patient perspective to start with, and that's probably your medication. But, so I will let...
I'm not on, like, if it's opiate medication, I'm not on any, and I do have hypersensitivity to foods. But when I took antibiotics, it really, I don't know if you're on antibiotics, but that really changed it. But hypersensitivity to smells, I can tell you if someone's smoking outside the door.
Yeah.
or any smells. Lavender, as Gracie said earlier, is really good. It helps with my migraines and headaches. But if it's a smell, especially something that reminds me of something bad in childhood, it really does affect me, and especially cigarette smoke, or any kind of smoke. If you blow out a candle, and I know that somebody blew out a candle 3 rooms over. So
Dr. Best is going to correct me and tell me the fancy word, but we are sensory sensitive. So all of your senses are heightened. But as far as not being able, tastes changing, I'm sure that all of the doctors here are going to say it's probably medication. So
No, I'm gonna make one comment on that. I said I've been doing a lot of interaction with Dr. Tobenek at the Institute of Neurological Recovery in Boca Raton. And he calls me up several times a week, all excited about his patients, and he has all his videos online. Just recently, he did do a video, and he called me up and told me a patient that came in, and within 5 minutes had normal taste return. They had a major taste problem before treatment, and within minutes after treatment, that's the first thing the patient made a comment. The gum they were chewing, the patient just sat there and was shocked.
that was after the...
After etanercept. Perispinal administration to the brain.
Remember what that hippocampus does.
Yeah.
Did you hear what Dr. Best just said?
No.
Remember what the hippocampus does. Memory, learning, ability to know.
To recognize.
Recognize, yes, sorry.
Were there any more questions from home? everyone watching and participating online, and all who are in attendance here at the Hilton, and from the Power of Pain, for the Power of Pain Midwest Neuropathic Pain Treatment Education Expo. The videos from today and the handouts from each presenter will be available online at the Power of Pain Foundation website starting November 1st as part of the November projects. Thank you to all of our exhibitors, the Power of Pain Foundation, Avison, Lupus of Illinois, Medtronic Neuromodulation, Midwest Acupuncture Group, Neurolumen, Pfizer, Purdue Pharmaceutical, Spiro Pain Relief, Teva Pharmaceutical, the Neuroscience Center, Hyperbaric Centers of Chicago, Whole Foods Northbrook. Also, thank you to our financial sponsors for providing the funding for this event so that it can be offered free to all of the providers and the public. The Neuroscience Center, Avison, John Webb, Neurolumen, Pfizer Pharmaceutical, Teva Pharmaceutical, Medtronic, Purdue Pharmaceutical, Spiro Pain Relief Therapy, and we had a few private donors. For those of you here in person, our event exhibitors will be here until 4 p.m., so if you've not stopped by, please take the time to do so. To today's presenters, exhibitors, funders, and attendees, thank you for your participation. And thank you for helping the Power of Pain turn pain into power.